Greetings from IAPD20 Virtual. This is Lecture 16, Evidence-Based Clinical Practice Guidelines. My name is Norman Tinanoff. I'll be chairing this session. Speaker for the session is Dr. Vineet Dhar, who's Professor and Chair of Orthodontics and Pediatric Dentistry at the University of Maryland School of Dentistry. Dr. Dhar has extensive experience with clinical practice guidelines as he serves on the 88 panels for non-vital pulp therapy, vital pulp therapy, and behavior guidance. Excuse me, that was the AAPD panel for non-vital pulp therapy, vital pulp therapy, and behavior guidance. He also serves on the American Dental Association guideline panels for restorative dentistry, caries prevention, and pit and fissure sealants. Some of the awards that Vineet has received in the area of clinical practice guidelines includes the 2018 ADA Evidence-Based Dentistry Faculty Award and the 2016 Paul Taylor Award for a systematic review evaluating the effectiveness of therapies for early childhood caries. This presentation today on clinical practice guidelines should enlighten and inform our daily practice of dentistry. Anytime during this presentation, you can ask a question by clicking on Q&A at the bottom of your screen. I will organize the questions and present them to Vineet for his answers at the end of the presentation. We welcome you, Vineet.
Thank you. Thank you for your kind words, Dr. Tinanoff. Greetings to all the participants. I truly appreciate your time, your being here. I hope everyone is staying safe and healthy during these very challenging times. It is indeed a pleasure to have this opportunity to share my thoughts with my esteemed colleagues from all over the world. These are great times from the perspective of global connectivity and collaborative work. Never before has communicating with colleagues worldwide been so easy and as open as it is today. And in my mind, it's only going to get better. This has opened up a new world of great opportunities to access and utilize collective wisdom to provide the best possible care for our patients. It is now perhaps more important than ever that we are on the same page at global level to what constitutes high quality evidence and how can we use it to improve patient outcomes in our practices. Healthcare providers, and I believe especially dentists, we are highly motivated in general to provide best quality care to our patients. And to achieve this, we engage in research, we engage in continuing education, we stay updated with the advances in materials, technology, and we are quick to incorporate scientifically backed interventions in our practices. This is all driven by the intention of providing best possible care to our patients. We now know that to provide best care, we must keep up with the evidence and keep our practices evidence-based, which takes us to our topic for today, which is evidence-based clinical practice guidelines. In medicine, the concept of evidence-based practice was introduced in the 19th century, but the first known formal clinical guidelines may have been written by Hippocrates. He was the first known to formulate formal clinical guidelines advancing scientific or systematic study of clinical medicine. He summed up medical knowledge in his work, Hippocratic Corpus, which was intended to serve both the physicians, the specialists, and the lay people. However, the concept of clinical practice guidelines, the ones we're talking about today, is fairly recent. It was actually in November of 1989 rather, that the Congress amended the Public Service Health Service Act to create an agency for healthcare policy and research. And this agency contacted Institute of Medicine to obtain guidance in areas of practice guidelines in 1990. And in 1992, the Institute of Medicine, the IOM, defined clinical practice guidelines as systematically developed statements to assist practitioners and patient decisions about appropriate healthcare for specific clinical circumstances. As Dr. Tinanoff said, I've been fortunate to have worked on Council on Scientific Affairs with AAPD and ADA, and serve on several work groups that are geared to producing clinical practice guidelines. the experience has been great while either leading those groups or working as a methodologist, or mainly I should say learning from the gurus in evidence-based practice. I think the more I've done this work, the more I've realized that it is imperative now that we as clinicians, academicians, researchers must have a thorough knowledge of clinical practice guidelines. The clinical practice guidelines are, I assure you, here to stay. They're only going to get more and more published over time, and they're going to play a much bigger role in how they guide our practices. So what's so different about clinical practice guidelines? So stay with me while I walk you through why do we need clinical practice guidelines? What is the process, very briefly, of developing clinical practice guidelines, and how, with some examples, these guidelines have impacted or are impacting the care we provide in our practices. Let's jump right into why do we need clinical practice guidelines. Interestingly, our healthcare system is very dynamic and evolving, and there are certain key changes that are happening in the current era, as you can see. One is the change from physician-centered to patient-centered care. Not too long ago, it was unthinkable, in my mind, I think, to question the physician's treatment plan. You would have to agree with whatever the physician said. This has changed over time at the global level, I think. And of course, this is for the better for the patients. Nowadays, it's important to incorporate patient values and preferences as an integral part of treatment planning. The shift has occurred globally, some countries maybe before than others, but it's taking place. Still, I would say for some medically complex conditions or life-threatening conditions, the care may be more physician-centered, but largely, and in dentistry for sure, with the concept of shared decision-making, we have shifted towards patient-centered care from the physician-centered care. And to provide patient-centered care, it is really, really key to keep it evidence-based. And evidence-based care requires systematic integration and judicious use of clinical expertise, the scientific evidence, and patient values and preferences. We've all seen this pyramid of evidence, and we've always heard and read that the systematic reviews are at the top of this pyramid. They constitute the highest level of evidence. I just want to put a caveat there that a well done or a high quality systematic review is what is really important. So one must appraise the quality of systematic reviews before you just start using the information from these reviews in your practices. So as clinicians, we perhaps have the know-how, or we may be in the position to do literature search, identify these key articles, appraise them, but it's very time consuming and resource sensitive. So we typically require expert work groups to help us with this kind of work. Second change that's happened is there's information overload. Great that we have global connectivity, but the real challenge comes in with way too much information that's coming our way as clinicians, and also our patients are exposed to the similar kind of information. Dr. Google is everywhere. We have unlimited access to information, tips of our hand, so we can, fingers rather, we can get to it very easily. But again, do we have the time, the ability to process this information and assimilate the knowledge that we need to? The output of scientific evidence is really immense, and a quick PubMed search on dentistry gave me I looked at years 2015 to 2019, and the articles published range from 26,000 to 29,000 in a year, which amounts to roughly about one dental publication being added every 19 minutes. That's a lot of literature for us and our patients to look at if we were to search for literature using internet. Even when we look at the expert panels that are in place, they have to review a lot of literature as well. These are examples of ADA or AAPD expert groups that conducted systematic reviews to create guidelines. And ADA, for their guidelines on sealants, had to scan around 5,000 papers. AAPD for vital pulp therapies, over 2,000 papers. And AAPD recently for non-vital pulp therapies had to scan over 10,000 papers. That is a lot of articles to go through to assimilate information and find out what is the best way of providing a certain care. And then this happens, these are recent publications, one in Journal of American Dental Association, one is in Pediatric Dentistry, both looking at the impact of radiographs, so visual inspection and radiographs for caries detection at 2 years time period. And their results are just the opposite. So the JADA paper says that simultaneous use of visual and radiographic methods for caries diagnosis in primary molars of children who seek dental treatment does not provide additional benefits compared to visual alone. And the IAPD paper says that clinical examinations without radiographs significantly underestimate caries prevalence. Therefore, use of radiographs should be encouraged in epidemiological studies and clinical trials. Of course, somebody has to read the paper in detail to see what was the difference in methodologies, what outcomes they looked at, and why do we have difference in the results that we see here. But this can be, of course, as you can agree with me, hopefully, that very conflicting and very confusing for the clinicians. So the question is, what's the solution? Is systematic reviews a solution? What are systematic reviews? So this is a high-level overview of all kind of primary research. So we looked at different kind of primary research that's been done. We identify, use proper search methodology, select the questions, select the articles, synthesizes, appraise it, and then we have collective high-quality evidence that answers, hopefully answers the question that's been asked. Very roughly, the first key thing in creating a systematic review is posing a clinical question that is based on the population intervention, the control, and the outcomes that are being studied. And once the question is formulated, you select the outcomes, you kind of rate their importance, how important are these outcomes that you're studying, and these outcomes are studied across the studies, different articles. You create a evidence profile using grade and rate the quality of evidence from high, moderate, low to very low, depending on several factors. For example, randomized clinical trials usually start at high confidence, observational studies start at a low confidence, and factors like risk of bias, inconsistency, indirectness, imprecision, publication bias, such things would lower the quality of evidence, and there are other things that would grade or improve the quality of evidence rather. The panel would give input on this, assess the overall quality of evidence, and put the systematic review together. Is that the answer? Or perhaps we also have meta-analysis. Is meta-analysis an answer? The only difference is that you can add a meta-analysis if you can statistically analyze the results being talked about in the systematic review. You can put together a meta-analysis, and you basically have a quantitative summary in addition to having a descriptive analysis. Here's an example of a presentation of meta-analysis, the forest plot. And since I'll be using a few forest plots towards the end to show the data used for clinical practice guidelines, let me really quickly refresh the different parts of a forest plot. So the first part is the descriptive part, which has different rows of studies showing what intervention was used, or what was it compared to, the weight of the study in that meta-analysis, and what kind of statistics was used. And then the graphical portion, which is basically the same representation of the descriptive part in a graphical way. The vertical line is a line of no effect, and then each study is in horizontal line, which is their confidence interval, and the little square in between is the point estimate. As the confidence interval crosses the line of no effect, it typically means that the intervention A versus B were not different. And then we have the cumulative effect, which will focus more on of the studies that were put together, and the horizontal width of this diamond represents the confidence interval. And the third part of the meta-analysis or the forest plot is the descriptive part, which shows the statistical significance of the study, or quantifies heterogeneity, or shows whether there is significant heterogeneity or not. The challenge, again, being, so we could look at systematic reviews and meta-analyses, and those were good solutions. But over the last 1 decade, if you notice that the number of systematic reviews and meta-analyses being published have really gone up. Now we're talking about, in 2019, close to 1,600 systematic reviews on dentistry and close to 1,000 meta-analyses on dentistry. So again, as a clinician, this is overwhelming to see that, okay, thousands of research papers. Now I want to narrow down to something which is more concrete, which kind of cumulatively gives me what these papers are saying, but then we have so many of those as well. So very overwhelming from that perspective. And the third thing which is happening in the healthcare is this global interaction has led to this evidence ecosystem. We are now depending on research done worldwide to inform local practices. So the way we conduct practices in a certain country, to inform that, we're looking at data which has been produced from the world, worldwide. So what are the things that we need to worry about? This is great collaboration-wise, but we need to make sure that the systematic reviews we're looking at are high quality. If they have garbage data and they're high quality methodology, the results are still going to be garbage. If you have perfect data and poor quality systematic reviews, the results are still going to be garbage. So we want to make sure that these are high quality systematic reviews that we're choosing. You could do a high quality systematic review, or there are certain tools like AmStar 2 to evaluate or appraise the quality of systematic reviews. But wait, what about the clinical expertise and the patient values and preferences? So our systematic reviews is just talking about the evidence piece. We need to put it in perspective for our practices. If we want to use global data and inform our practice in the local population, we have to put that data in perspective, or rather contextualize it for our population. That is the key that we need to think about while utilizing this data. And that is where the guidelines come in. Now, you will see two variations of these guideline documents, and they're loosely called guidelines, but one of them is the clinical practice guideline and another one is best practices. So the clinical practice guidelines that we are really focusing on, and I'll talk a little bit about best practices as well, but the clinical practice guidelines are statements that include recommendations intended to optimize patient care, but they're informed by systematic review of evidence. That's an important word there. It is informed by systematic review of evidence and assessment of benefits and harms of alternate care options. So that is really, these two factors are really important in producing clinical practice guidelines. Let's look at best practices. Now, CDC defined best practices as the best clinical or administrative practice or approach at the moment, given the situation and the consumer's needs, the community needs and desires, and the evidence of what works for the condition, the situation, and the resources that are available. So it's a more open kind of a statement. And it's typically, you will see people coming up with, or organizations coming up with best practices mainly on consensus. You will see some variations. For example, IAPD uses expert groups from their Council of Clinical Affairs and Council of Scientific Affairs. And they identify work groups, small work groups. These work groups work together, do a literature search using a proper strategy. And then there's debate and deliberation to come to a sort of a best practices document. And you will also see more recently, though this is not a new methodology at all, that Delphi process is being used by several authors for coming up with sort of best practices, getting consensus in a different way by using Delphi process. Delphi process, what is that? Well, I'm sure you guys know you pose this question, you identify key stakeholders, a work group, if you will, have the experts answer the questions in 2 rounds. So you do the first round, they give responses to you, you revise the earlier responses, and based on the comments, you will do that revisions, and then send it for second round. And finally, the answers that have received consistently higher agreement rating would be included, and this will help converge towards the correct answer. Then there is also a concept of modified Delphi, which basically added a face-to-face meeting to the 2 rounds of original Delphi process. And the rationale was that you want to give an opportunity for people to voice their concerns, to speak. And so the modified Delphi process was used to create, again, best practices statements. Now, what are the limitations of these consensus-based guidelines? Well, they can be used, but if we're using them, let's be sure that we know, we understand, and our patients understand that the best evidence is when it is derived from systematic review of best possible or best available literature and rigorous quality of evidence. Now, our consensus statements do not do this. Second, we must recognize that there's a distinction between evidence-based clinical practice guidelines and consensus-based guidelines. Though both involve a consensus process in a way, evidence-based guidelines also involve net benefit analysis, which involves consensus process. But there's a difference, and it can be misleading to our readers, to our patients, to our clinicians, if they do not recognize that one is based on systematic search of the best evidence and other is a consensus process. So we need to make that distinction. And third, again, like I said, a clinical practice contextualized evidence, they rely on patients' values and preferences. There's a net benefit analysis that is missing in consensus-based guidelines. So is there a concern with that? Yes, well, if you can do clinical practice guidelines, it's always the best thing to do. But sometimes you need to settle with best practices, position statements. But the concerns are, there's a consensus from leaders, that's fine, but there could be lack of transparency, there could be biases, there could be conflict of interests, and they may not be as well received as a evidence-based clinical practice guideline would be. So in what situations can you really put together a best practice? And some places in medical literature, they're referred to as good practices statements. So if you look at Dr. Guyot, the guru of evidence-based medicine, he put together a checklist in one of his papers that when can you use good practice statements? He says when the statement should be actionable and clear. Well, that's true for clinical practice guidelines too. He says we have to understand, is the message really necessary in regard to actual healthcare practice? Second, will implementing the good practice statement result in a large net positive consequence? Third, is collecting and summarizing evidence a poor use of guideline panels' limited time and energy? So in other words, is the opportunity cost too large in creating clinical practice guidelines? Is there well-documented, clear and explicit rationale connecting indirect evidence? And the papers goes on to say that if you address yes to all of these questions, you may proceed with a good practice or a best practice statement. Otherwise, you should try your best to come up with a clinical practice guideline to support and guide your practice outcomes. Let's touch briefly on what is the process of developing clinical practice guidelines. Now, there are several groups that are involved in creating clinical practice guidelines, more in medicine and perhaps lesser in dentistry, but I think they're picking up. I really feel pediatric dentistry is leading in this compared to other branches in dentistry. And there are also several groups that provide guidance on how to create and how to report these kind of guidelines. But very basically or broadly speaking, evidence-based clinical practice guidelines directly link and inform their recommendations to scientific evidence. So they have two main parts. One is a high quality systematic review. So either you do that high quality, that expert group that's put together, work group, either that work group conducts that high quality systematic review, or you appraise existing systematic review using any of those tools that are available. Like I said, AmStar 2 is one of the new tools available. So use one of those to appraise and see if you have a high quality systematic review. Please do not, it's not recommended to base your guidelines on a low quality or a moderate quality, if you can, systematic review. If the conditions do not allow any other systematic review, then you can perhaps get into more details of why you chose a lower quality and explain that in your paper. But as much as possible, choose a high quality systematic review for conducting or creating your clinical practice guidelines. And the second part of it is formulating recommendations, basically moving from evidence to clinical decisions. And the process for that, as we saw that the process for creating systematic reviews, this is a continuation of that, where the panel would look at the overall grade assessments and then create recommendations for or against a certain intervention, and assess the recommendations to be strong or weak. Sometimes authors use conditional instead of weak. And this is done by considering quality of evidence, the net benefit and harms, the values and preferences of the patients, and sometimes looking at the resource use, the costs. Is it applicable in the population you're looking at? There may be an intervention that it may be affordable in a certain part of the world, and a different part of the world that may be adding too much to the cost or resource allocation and may not make much sense in light of other possible alternatives. So you have to kind of value those things in and then produce guidelines. So systematic review done on global data, looking at studies from all over the world, great idea. When you're recommending practice guidelines, clinical practice guidelines for your population, please make sure that you use the factors that are the benefit and net benefit analysis applied to your population, and see how the clinical practice guidelines apply to your population. And then finally, you would produce recommendation statements. The recommendation statements may have verbiage like must, if the recommendation is really, really found to be an important one and strongly recommend that you do it. It may have the verbiage of should, if we feel that the recommendation, that it's highly desirable that the provider uses that intervention, or it can be a suggestive or may kind of a language which says that the provider can consider other options and see how he wants to use that clinical practice recommendation. The key, again, other than systematic search of evidence, is that there is net benefit analysis. So in clinical practice guidelines, we look at the quantitative summary that we did based on the systematic review, the meta-analysis, but we also look at the qualitative summary. We also look at the qualitative data that perhaps wasn't suitable for meta-analysis, but it does give you valuable information. And then combine it with the treatment effect, the balance between benefit and harm of the particular intervention, burdens related to that intervention, resource allocation, costs, patient values and preference, and the quality of evidence that you have. Put all these together and then balance it out. So for example, if you're really certain, the level of certainty for a certain intervention is really high and the benefits really outweigh potential harm, you could give a strong recommendation in favor of that, that intervention. But if the level of certainty is high of the data, but there are potential harms from the intervention, so you're saying with high certainty that there is harm, then you could give a recommendation against it. What you must remember when you interpret these guidelines is it's not a good idea, except for very specific circumstances, to base high quality, give a strong recommendation rather on low or very low quality evidence. It is like saying that you don't trust the evidence you have, but you're saying that, you know, you're giving a strong recommendation based on that. So that should be avoided. So most of the times you will see a conditional or a weak recommendation being given for low or very low quality evidence. All right, let's now look at how do we interpret these clinical practice guidelines. So when we look at the recommendation statement, we know that it's a clear and actionable statement. It's formulated by a guideline panel or a work group to assist clinicians deciding the best course of action for their patients. So there are three parts to that recommendation statement. The first part is the written statement. For example, this is for a vital pulp therapy intervention. It says the panel strongly recommends the use of MTA in vital primary teeth with deep caries lesion treated with pulpotomy due to pulp exposure during caries dentin removal. So it's recommended, strongly recommending use of MTA. The direction of recommendation is in favor of MTA, not against. The second part is the strength of recommendation, where it says it's a strong recommendation or it's a weak or a conditional recommendation, right? And the third part is the quality or certainty of evidence, which basically is saying how much confidence we have in the effect estimates. And based on these, we define what these really mean. So for example, the quality of evidence high would mean that we are very confident in the true estimate, and that aligns very close to the estimate of effect that you have come to from the study. So we're very confident that these align. In moderate, you're moderately confident in the estimated effect, and in the low, your confidence in the effect estimate is limited, and there may be some variation from the true effect. And in very low, you have very limited confidence in the effect estimate from the meta-analyses, and you feel that the true effect could be significantly or substantially different from what you're seeing. So that's why it's very low quality. For the strong and conditional, and I'll stick to just what it means to clinicians, for clinicians, when you give a strong recommendation, it should mean that people should receive this kind of intervention. It can be used as a quality criteria or a performance indicator. But if you give a conditional recommendation, it really means that there are other options out there. You should consider patient values and preferences. You should look at other options and manage and reach your clinical decision based on all of these things. So there are really two key concepts happening here. One is the estimate of treatment effect or the risk of experiencing an outcome. And second is the quality of the evidence. And this is explained in this cartoon very well. If the cartoon says, I figure there is a 40% chance of showers and a 10% chance we know what we're talking about. To build on that example, for example, if I told you that I have a device that tells whether it's going to rain today or not, and I tell you that your device is telling me there are 90% chances of rain today, but the algorithm this device uses, the science behind this device, I'm not sure about it. I just don't have enough confidence in that science, maybe 10% confidence. Are you likely to believe that estimate of 90% if the device, we don't know whether the science behind it is good? Or if I said the device is saying it's going to be 90% rain and the algorithm it uses, the science behind it is really sound, it's really high quality, then it's more likely that you would believe in that. That is what the concept behind it is, that you need strong quality or high quality evidence to base a strong recommendation on it. If the quality of evidence, and that could be because the research done had methodological differences, there was imprecision, heterogeneity, a lot of things can happen. And the quality of evidence that you have right now, the best evidence that we have right now is not high quality, it's maybe low quality, it may be very low quality. That's fine. We can base our recommendations on that, but we will just give it a conditional or a weak recommendation. Now, applying this to a clinical scenario, seeing how evidence-based clinical practice guidelines or let's say evidence-based dentistry has influenced clinical care in areas of restorative care, sealants, and non-vital pulp therapies. I picked some examples. I'll just go over these examples real quickly. Hopefully I can give examples for best practices using Delphi process and the clinical practices. So how has the evidence influenced restorative care? This is an example for best practices. Looking at this graph published in 2015, if we were to review this, it basically is a distribution of decayed and filled surfaces in ages 2 to 5. And from 1988 to 2012. So in 1988 and 91 data, you would see that decayed surfaces, the one with the solid colors in the front, and the restorative with the stripes at the back. The decayed surfaces are around 1.2, restorative was about, surfaces were 1.8, and over time, in 2012, the decayed surfaces really fell down from 1.2 to 0.4, and the restorative surfaces really came up to about 2. And the thing is, the question really we have to ask ourselves is, have you really taken care of these kids? Now, if you remember, we define early childhood caries based on the decayed and filled surfaces. So it's based on the clinical experience, not on untreated caries only. So even filled surfaces are counted towards experience or having early childhood caries. So clinical experience of caries is the key here. So if we look at this and try to ballpark the numbers here a little bit, so in 1988 and 91 data, we saw 1.2 of decayed surfaces, about 0.8 of filled surfaces. DFS was close to 2, very roughly speaking. And in 2011-12 data, the restored surfaces were 2 and decayed surfaces were 0.4. So kind of reversed, but the decayed filled surfaces is the caries experience is 2.4. So it's not really gone down as far as the caries experience is concerned, but we have fixed more teeth. So as long as fixing teeth is fine, we should be okay, right? So question really is standalone restorative care effective in children? And then there's a lot of work done in this area, and I've just put one of the meta-analyses. They looked at effective restorative care on cariogenic bacteria like mutans, streptococci, and lactobacilli. And this forest plot, pardon me, shows that there is a reduction in the mutans, streptococci, and the lactobacilli count. The big diamond right here shows the reduction is in both after restorative care. The only problem is that this reduction in the counts of bacteria is short-lived. So after 6 months or so, you start seeing that the oral microflora starts going back to where it was. Another study showed us relapse rates. And in 2 years, for the 2 years data, the relapse rate varied from 53 to 79%. So children who had received restorative care, and these were all in the OR, had from 53 to 79% of them had new caries or recurrent caries. So there is relapse. Looking at these factors, it's important to think the science moved towards paradigm shift was towards the chronic disease management model. And the evidence showed that we should have protocols that include disease management and include in-office and at-home interventions. Both are important. Looking at caries activity was important, new lesions was important, caries risk was important, whether the disease is controlled or uncontrolled, and you would base your interventions on that. A study by Ang in 2012, they looked at simple strategies in chronic disease management, how it impacted over 18 months, outcomes like new cavitation, pain, and referral to the OR. And they found in the 2 centers they did the study that it reduced, there was improvement by reduction in all these 3 areas at both the centers by 65%, 38%, 48% for referrals in the Boston Children's Hospital Center, and similar reductions in the other center. So there was significant reduction just by putting a caries chronic disease management model in place. Now, IAPD has been doing this for a while. So they put these best practices together, which shows these care pathways that's exactly based on the disease management strategies. This is a great example of best practices, where you identify the population based on the risk. You figure out what diagnostics are required, what interventions are required, and provide this care pathways to the clinicians, make it really simple. This is what you need to do a proper disease management model. A great example for a best practices document. Now, an example for Delphi process, a recent publication by Splythe et al. 2020 actually in caries research. This paper looked at using a Delphi process, so they identified key stakeholders or their work group from some experts from the European Organization for Caries Research and European Federation of Conservative Dentistry. And they put together some clinical questions. For example, how should one intervene in early childhood caries? What should be the non-invasive treatments for ECC? What should be the invasive operative treatment options? They put together some clinical questions, which was a little different than the best practices we saw before. It was more of a review, and the findings were put together from that perspective. In this model or variety of best practices, if you will, there is a posing of clinical questions, which is similar to clinical practice guidelines, but the difference is that there is no systematic search of the best evidence. There's no assessment of certainty of evidence. There's no assessment of net benefit analyses, but what they do is they do assess the strength of evidence based on quality of the papers that we'll see. So if they were high quality randomized clinical trials, if it was a higher quality of evidence, the strength was weak if there were lower quality evidence. But they basically answered questions in this paper. So again, from a clinician perspective, it's a good document, but it's still a best practices document, maybe slightly modified because of the limitations it has, maybe a little weaker document than clinical practice, but it's a good document to look at for clinicians to say, okay, I have this question and I think it's answered here. Another example of where authors, this is Schwendeke et al. In 2019, used the Delphi process to come up with algorithms which would guide clinicians on what they should do, in this case, how to intervene in the caries process, depending on whether the caries lesions are active, whether there's cavitation, what is seen radiographically, and then they looked at different strategies, possible options, and combined them together and came up with this algorithm. This, again, very helpful for clinicians. Let's look at some examples for clinical practice guidelines now. So how, again, clinical practice guidelines, there will be a clinical question to begin with. There will be posed clinical questions a priori. They will be decided beforehand, and that's how the search will be conducted, depending on the population and interventions. So this question was, how has evidence influenced the use of fissure sealants? 2011 survey showed that less than 40% of dentists in US seal non-cavitated caries lesions. The ADA 2016 paper, this is the forest plot, showed in 2 to 3 years, by use of sealants, you could reduce caries by 76%, 0.24 of odds ratio, which becomes 76% reduction in caries if you use sealants. So the ADA was able to recommend use of sealants compared to non-use in permanent molars with both sound occlusal surfaces and non-cavitated occlusal caries lesions. A big change, a strong recommendation on a moderate quality evidence. So it's a really strongly supported kind of a statement. It means there's a lot of literature to support this kind of statement. Now, I know that this is being taught in schools. I know that this will change, maybe not now, but over next 10 years perhaps, when we do the survey again, if somebody does a survey again, I'm sure there'll be a lot more dentists who will be using sealants as a preventive mechanism, because this is such a strong statement coming on use of sealants. How has evidence influenced non-vital pulp therapies? And this clinical practice guideline is actually in process of being published, and many questions were asked. I just selected a few of them. The first question was, in non-vital pulp primary teeth, does pulpectomy have better long-term success in teeth with or without root resorption? So root resorption, yes or no? How does it impact success in pulpectomies? So the data on 12 months and 24 months shows that those without root resorption had a statistically significant higher success, 89% compared to 47%. At 12 months, 88% compared to 59 at 24 months. So if there's no root resorption, really good for pulpectomy as an option compared to if there's root resorption. And based on other benefits, harm, quality assessment, it was decided that this is a conditional recommendation because it was based on very low quality of evidence. And it was very low because there was serious heterogeneity. There was serious indirectness in the data that we collected. And for the 24-month, there was even risk of bias. So there was very low quality evidence, and the statement was conditional. Another question, people use rotary instruments, people use hand instruments for doing pulpectomy. So the question was, in primary treated with pulpectomy, does instrumentation, hand versus rotary, influence treatment of success and quality of fill? So the meta-analysis showed that comparing rotary to manual, there was a significant difference favoring rotary. It reduced the time by about 2 minutes. And the optimal fill was also better in rotary, but not significantly better, okay? So given that, and given the resources needed to use rotary, the training needed to use rotary, the panel decided, looked at all these factors, and did a net benefit analysis and said, rotary instruments significantly reduced the time by 2 minutes. But considering all the findings and additional resources and training required, clinicians can use whatever they want. Is 2 minutes of benefit enough for clinicians to invest in a rotary system or switch from hand instrumentation, leave that completely and go to rotary? That's perhaps we don't have enough strong evidence to say that. So again, a moderate quality, so a conditional recommendation rather, but the evidence was moderate quality. So it was pretty good evidence. We could have given a strong recommendation if there was significant differences and if the net benefit analysis showed significant value of an intervention. But in this case, the net benefit analysis did not show significant value of using rotary over hand instruments. So the recommendation was still conditional. Similarly, for use of obturation materials, we did a network analysis for 18 months, and the ranking was for highest for zinc oxide iodoform and calcium hydroxide mix, which is endoflas, and followed by zinc oxide eugenol, and followed by iodoform. The success at 18 months was at 90% for the mix, and it reduced to 71% for iodoform. So our statement was that evidence suggests using zinc oxide iodoform and calcium hydroxide and ZOE over iodoform as a filler. But again, very low quality evidence. It's a conditional recommendation. It's not compelling that you must do it, but it's a suggested. If you have access to it, please do it. Similarly, another question on LSTR. And we asked if there is significant root resorption greater than 1 millimeter, internal or external, how does LSTR compare to conventional pulpectomy? And our forest plot showed us that it was significantly favoring LSTR when there was root resorption. So the first one showing root resorption, yes, shows much higher success with LSTR, about 76 compared to 47 in pulpectomy. If there was no root resorption, then pulpectomy did better than LSTR. But the problem here was that LSTR, the data was not, we don't have long-term data, and there's some adverse events noted, like enamel defects, rate of resorption. So panel was careful. I think there's a need for following up. There's a need of more long-term studies. So we said if the clinician decide not to extract, that's always an option. They can choose to do LSTR over pulpectomy if there's preoperative root resorption, but follow it up with x-rays after every 12 months. Again, the quality of evidence was moderate, but looking at the potential adverse events, we gave a conditional recommendation. The last one that I have is when doing LSTR, how does traditional 3-mix with tetracycline compare to alternate 3-mix, which is without tetracycline, clindamycin in most cases. And the data showed that there was statistically significant less success with the traditional mix with tetracycline, 56%, compared to the one without, about 76%. Now, given the potential, there's no documentation to say that tetracycline and 3-mix can cause any discoloration to teeth, but a potential chance of adverse event and significant difference, anyway, alternate mix is doing better. The recommendation was in support of using alternate 3-mix compared to traditional 3-mix. So why use the mix with tetracycline if the other one is doing better? There's no advantage of it, and there's a potential harm. So while it's a very low quality evidence, the recommendation was conditional, favoring use of alternate 3-mix. With the help of these guidelines, we were able to put this algorithm together, which guides the clinicians, hopefully will guide them depending on what the condition of the pulp is, whether the tooth is restorable, the status of root resorption, to choose between pulpectomy, extraction, and LSTR. Now, it's as I've said this, to provide patient-centered care, it has to be evidence-based. Sooner or later, the evidence pyramid will be modified to show what I'm showing here. The clinical practice guidelines fit above systematic reviews because it uses the best evidence by a systematic search and does a net benefit analysis, applies it to your population. Plus, if you look at the convenience of this, I mean, pick any topic, let's say sealants. If you were to research, if you put a research group together and they look at the papers to review sealants, they have to scan 5,000 papers. If they want to look at systematic reviews, they still probably have to do, they're probably 10 to 20 systematic reviews or more on sealants. But there's only one clinical practice guideline. Maybe there are two, I don't know, but there's one that I know of. And that uses the best quality evidence, and that uses net benefit analysis that you can modify for your population. So this is the resource that you need to understand, use in your practices to improve the patient outcomes in your practices. But please remember, guidelines are to inform, not to dictate. They're to guide, not to enforce, and they're to support, but not restrict what you do in your practices. With this, I want to thank all of you again for your participation. And back to you, Dr. Tinanoff. I'm open to questions.
Okay, very good. Very informative, Vineet. We have some questions that I'd like to propose to you. Um, there was a question about quality of systematic reviews. How can a clinician be able to interpret what is a high quality systematic review? What should a clinician look for?
Thank you. Thank you for that question, Dr. Tinanoff. There are very simple tools out there that a clinician, if you are into reading systematic reviews, I would suggest invest a little more time. And these are very friendly. The one that I named was AmStar 2, AmStar tool, and there's a CASP tool. There are online tools available that you can easily use to appraise a systematic review. When you start reading a few of them, and soon I'm hopeful that you will not need those tools, you will be able to, by just reading and evaluating them, assess that have they covered all the requirements that are dictated by PRISMA in reporting standards in systematic reviews.
Okay, very good. Here's another one for you. How is the expert panels selected? Who does that? That's very important. Who's selecting these experts for these panels?
So the work groups that I work are either by American Dental Association or American Academy of Pediatric Dentistry. These are national organizations that have scientific councils, scientific committees that look at the research out there. They look at, they put work group together. Their scientific committee puts it together. AAPD has an evidence-based committee that looks at the topics, selects the topics, and puts work group together based on what work they've been contributing to. But I also want to go back put the question back to you, Dr. Tinanoff, because I know you have a long experience in this area. So if you want to add anything to that, please do.
No, I'll leave your answer as being a good one. But there's a parallel question that just came in, and it's, do you think that clinical practice guidelines should be led by WHO or dental academies?
It depends on what we are looking at. I mean, I personally don't know if WHO is leading any clinical practice guidelines. I don't see a problem why they cannot. The key there is to identify a scientific group that can overlook these functions, and that scientific group puts together these experts, work group members who have expertise in areas of producing clinical practice guidelines. I believe all of these organizations can participate in this. The more, the merrier.
Yeah, okay. So there's a question about which to follow. Strong recommendations but poor quality evidence, moderate recommendations but good quality of evidence, or moderate recommendations but with moderate quality of evidence.
Okay, well, I hope you don't come across strong recommendations on poor quality evidence, which is what I was saying, that it's not wise to say that we strongly recommend an intervention, but we're not sure of the science behind it. So typically you will see strong recommendations being backed up with high or moderate quality evidence. Those are really good to follow. But if you don't have those, your next bet is conditional recommendation based on low or very low quality evidence. That's fine. Only thing is, as long as you understand what these recommendations mean and how strong the science backing it is, it's fine. It's your as a decision as a clinician. That's why the clinical expertise, patient values becomes so important. It's not only the evidence that's important.
Okay, this is the last question and a tough one.
Okay.
So there's a study that was done in Chennai, India, that shows amazing results of product X in reducing early childhood caries. How is a clinician in England going to understand how this may affect his or her practice?
Well, hopefully the product is really effective. There will be more studies done on it, and it will gain visibility and interest in international market. Till that happens, it's difficult. But like I said, these days it's such a connected world that we are reading research and literature being published everywhere. If you think you have a product or an intervention that's really effective, I think it's really important that the visibility of that intervention is improved in some way or another, so more people can do more research on it, and it can become a part of the standard of care if it's worth it, for sure.
Okay. Question just came in is, can you give us some tips? This is similar to what we had before. Some tips to evaluate the quality of systematic reviews or meta-analysis.
Some tips.
Besides going to literature or things that are published, what can a clinician look for to decide the quality of a systematic review?
Sure. I think basic things like what kind of clinical question has been posed? Are they really talking about or included, have they included properly, adequately the population intervention, the controls, and the outcomes they are studied? Have they used a good search strategy, a thorough search strategy? Have they defined what they have searched for? Have they defined the outcomes they have looked at? And the clinical questions, are they of interest? If you're happy with the methodology and the search strategy used, a lot of times you can utilize that data, even if they are not directly answering the question you may be looking at. So at least those to begin with. But like I said, let me repeat myself, those online tools are really friendly and really simple to use.
Okay. So these questions have been very, very good, and thank you for those answers. And I think that's the end of our questions. So I thank you very much for your presentation, and I hope that people start using clinical practice guidelines in their everyday practice of dentistry. So thank you very much, Dr. Dhar.
Thank you so much,
Bye-bye.
Dr. Tinanoff. Bye-bye.